Hi everyone, I'm Laura Waters from Central London. I'm an HIV clinician and I'll be talking about Integrase toxicities and their management. These are my disclosures. So I'm going to be covering initially the challenges of capturing and interpreting adverse events. I will then look at the issue of whether integrase inhibitors are better tolerated than other antiretroviral classes, and I'll finish on a comparison of individual integrases and whole regimens with some tips on managing associated adverse events. So starting off though, just a reminder that unboosted integrases are preferred for first-line therapy in guidelines. These are the October 2020 EACTS guidelines, and you can see across the board it's unboosted integrases with a 2-NRTI backbone, or in the case of dolutegravir, also the dual option of dolutegravir and lamivudine for first-line therapy. The US DHHS guidelines are similar, unboosted integrases in triple therapy, or again, dolutegravir also recommended as a 2-drug option with lamivudine. So why are the unboosted integrases recommended first line? Obviously, most importantly is efficacy, and this is a class that has been non-inferior or superior to NNRTIs and boosted PIs in many studies. The main exception is switch Merck, where raltegravir was inferior to boosted lopinavir, but that was in a population with NRTI resistance. As a class, they're largely well tolerated with low toxicity rates and relatively few drug-drug interactions. And right now, the second generation integrases are the only unboosted drugs with a high barrier to resistance. Now, before we move on to different classes and specific drugs, I just want to touch on some of the important principles when it comes to interpreting adverse events. And you really must bear these in mind when looking at potential differences, particularly between trials. Now, firstly, adverse events can be hard to interpret. Populations may have differing baseline demographics. Adverse events reporting is often clumsy. I'll come back to that. There's the impact of placebo, which I think we sometimes forget, and also interpretation can be subjective. Thinking about baseline characteristics, a good example is lipid changes. Lipid changes are a very commonly reported endpoint in clinical trials. However, lipids at baseline will vary significantly between populations. So, for example, there's a relationship between higher viral load and lower LDL. And also age is associated with total cholesterol. So if you have populations with differing baseline viral loads or differing average ages, that may well impact baseline lipids and therefore lipid changes subsequently on treatment. Let's take 2 studies looking at lipid changes first line. On the left, we have START Merck, which is a comparison of raltegravir with efavirenz, and on the right is Drive Ahead, also efavirenz, but here compared with the NNRTI doravirine. In both, it was a TDF and emtricitabine backbone. Now, you look at this and you see that lipid rises were significantly greater for efavirenz in both studies, which we would expect. But actually, for Drive Ahead, doravirine was associated with reductions in some lipids, whereas raltegravir in START Merck just smaller increases than efavirenz. So you could look at that and think maybe there were differences between raltegravir and doravirine. However, if we look at the baseline characteristics, START Merck was undertaken many years before Drive Ahead, and you can see that the people with advanced HIV in terms of a low CD4 or high viral load were much more frequent in START Merck than Drive Ahead, where those late populations were much smaller. In addition, there were some differences in baseline age. So this is just to highlight that it's really difficult, if not impossible, to cross-compare these 2 studies. Coming back to my point about clumsy adverse event reporting, this is an example I use often because generally we see adverse events reported as the prevalence, i.e. what proportion of people experience them at some point over 48 weeks. Now, if I asked you all, I can't see you unfortunately, but if I asked you all, you have a choice between drug A and drug B. Drug A has a 50% chance of causing diarrhea, and drug B has a 5% chance. Based on that, I think most of you would choose option B. However, if we report adverse events a little less clumsily and think about duration, and I now say to you, drug A has a 50% chance of causing diarrhea, but only for 2 days, whereas drug B has a 5% chance of causing diarrhea, but that will last 12 months. I imagine most of you would now go for option A. And actually, this graph here is a good example of how I think all adverse events should be reported. This is a combination of 2 Gilead studies looking at Stribuild. But the point is, you look at the prevalence over time. So at any given time point, what proportion of people have that side effect? Those are the lines on this graph. The bars show the incidence. So at each time point, what proportion of people got that side effect for the very first time? And this kind of description of adverse events, I think, is much more meaningful when it comes to counselling patients. What we can say here, for example, is if you didn't have abnormal dreams within the first 4 weeks, regardless of treatment arm, you were unlikely to develop that side effect subsequently. I'm also going to use this graph to illustrate the point about placebo. Now, these were 2 studies comparing Stribuild, cobicistat boosted elvitegravir with TDF and emtricitabine in a single pill. In one study, the comparator was efavirenz. In the other study, the comparator was atazanavir ritonavir. Now, these studies were blinded, so people didn't know what they were taking. The very top line is abnormal dreams on efavirenz, which is expectedly high. But the next line down is abnormal dreams on Stribuild. Now, you could look at that and say that 9% of people on Stribuild have abnormal dreams by week 48. However, the other Stribuild line at the bottom in yellow is 0%. And here the comparator is atazanavir. So this shows the difference in abnormal dreams on Stribuild depending on what people thought they may be taking. And in the blinded efavirenz comparator study, abnormal dreams were much more common. So I think this really well illustrates the impact of placebo. And then finally, causality. So we may describe and measure and report adverse events, but it's down to the investigator on a trial to decide whether that adverse event is drug related. And this can clearly be subjective. And my fear is the bias of familiarity, that we are more likely to say a drug is causing an adverse event if the drug is already known to cause that adverse event, which may mean we under-associate newly emergent adverse events with drugs because we're not yet familiar with that side effect. Optimal adverse event reporting, I think, would be like that graph I've shown you with incidence, point prevalence, and grading. We should see all adverse events reported as well as those considered drug-related, and also think about clustering. So if, for example, we know that most people who get insomnia on a drug are the same people who have low mood, that will help us counsel patients. And really importantly, in the modern era, I think the impact on activities of daily living and on quality of life through patient-reported outcomes is really important. And it's good to see trials considering patient-reported outcomes more often. So moving on to question 2, are integrases as a class safer and better tolerated? Now, against protease inhibitors, undoubtedly, yes, they are. I think that's best illustrated by ACTG 5257, which was a large first-line study with 2 PI arms, atazanavir ritonavir and darunavir ritonavir, and an integrase arm of raltegravir, all given with a tenofovir, disoproxil, and emtricitabine backbone. And you can see from the discontinuations for toxicity, the very top line, particularly atazanavir, but also darunavir, more common than raltegravir. The other thing to consider is not just the direct toxicity associated with PIs, i.e. side effects caused by those drugs, but also the higher risk of indirect toxicity thanks to boosting. And for example, the interaction between boosters and steroids and boosters and statins, which can result in iatrogenic Cushing's and in myotoxicity, respectively. What about against NNRTI? Now, it's a challenge because efavirenz is one of the most common comparators in historical studies, and all core agents compare favourably against efavirenz. There's a possibility as a class, integrases are associated with less hepatotoxicity, and that was demonstrated in the Italian ICONA cohort, which looked at more than 6,500 people starting first-line ART. You can see roughly similar proportions getting a PI, NNRTI, or integrase at baseline, and they described 183 liver enzyme elevations in over 20,000 patient years of follow-up. After adjustment, this graph shows the top two lines are PI and NNRTI. The bottom line is integrases, so about half the risk of liver enzyme elevations on integrases. Now, this is partly complicated by the fact that due to the calendar period, some of these are going to be older NNRTIs and PIs, and repeating this in the more modern era would be really helpful, but definitely fewer liver enzyme elevations on integrases. And actually, that was particularly true for raltegravir, the lowest risk of liver enzyme elevations on that particular integrase inhibitor. Moving on to a very discussed toxicity of weight change. This is a graph that's been shown in many presentations, but essentially showing us that the second generation integrases and TAF particularly associated with weight change. Now, whether second generation integrases and TAF are causing weight gain or whether older drugs were causing relative weight loss is a hotly debated topic. I'm sure we'll be hearing more about it, but certainly there is this signal for second generation integrases and TAF-based therapy. If we look at doravirine as a more modern NNRTI, this is from first-line studies as well, doravirine in green, darunavir in blue, and efavirenz in the purple, and you can see numerically more weight gain on doravirine. However, the difference is less marked perhaps than we're seeing in some of the integrase studies, complicated, however, by the fact that it was TDF in the doravirine studies rather than TAF in, for example, the bictegravir studies. So you're seeing less of an impact on doravirine, complicated by a different backbone. But the point I really want to pull out here is the difference between median and mean. Here we have mean on the left, associated with numerically greater weight gain than when you look at median on the right. And that's to be expected because median is less impacted by outlying results and may be the more accurate marker. Now, weight in isolation is not as important as weight considering other factors. Now, one of those is other metabolic parameters such as lipids, and we'll touch briefly on insulin sensitivity next. But also there's the quality of the fat, and there's an emerging understanding that there is good fat and bad fat being denser and more metabolically active. And there's some data presented at HIV Glasgow last year doing DEXA and CT scans in people who'd gained weight. Some had switched to an integrase and some hadn't. Now, the people who'd switched to an integrase gained more weight than the people who hadn't, but their visceral fat was less dense, which is a good thing. So the idea that the integrase-associated weight change may be somehow less harmful is an interesting concept, and again, I'm sure we'll hear more about it. Thinking about other metabolic parameters, here's the example of insulin sensitivity. This is TANGO, where people on suppressive 3-drug ART based on TAF either stayed on their TAF triple therapy or they switched to dolutegravir lamivudine dual therapy. And there were significant improvements in insulin sensitivity. Now, was that removing the TAF? Possibly, but it's complicated by the fact that most people are on a booster. In fact, 2/3 of people were on COVID-boosted elvitegravir, and you can see that the insulin sensitivity improvement only remains significant for people on a booster at baseline and was not statistically significant for those who were on an unboosted regimen. What TANGO really can tell us is people switching off COVID-boosted elvitegravir and TAF FTC do see insulin sensitivity improvement when they switch to dolutegravir lamivudine. What about the management, though, of weight gain? I think the most important thing is counselling patients. Whether it's true drug-associated weight gain, whether it's removal of other drug-associated weight suppression is kind of irrelevant, but a counselled patient tends to gain less weight than a non-counselled patient, and that's been established in the field of psychiatry. So warning people, regardless of the mechanism that they may gain weight, means they should gain less weight. Measuring weight, of course, is important, but giving accurate advice. And when it comes to weight loss, there is a huge amount of evidence about what are the best strategies. And although exercise is good for you, It's hard to exercise yourself out of weight gain. Diet here is really, really crucial and probably the most important factor when it comes to losing weight. But understanding the data, keeping on top of the latest evidence, and ensuring we understand the mechanisms that drive this, again, are going to be really important for us to give the best advice we can to our patients. Now, finally, thinking about comparisons between integrases, I'm going to focus on two key issues. The first is, I apologize, not CNS toxicity, it's myotoxicity. Then I will focus on CNS toxicity. But I'm going to consider particularly the importance of other components in a regimen. Now let's think about some key integrase toxicities. I've mentioned myotoxicity, we will talk about that next, but that was a side effect that really first emerged when raltegravir use expanded. There's the CNS toxicity I've mentioned, and of course, we have already covered weight, and I won't talk about that further. So myotoxicity, when raltegravir was first introduced, there were some case reports which prompted case series and cohorts. Now, asymptomatic creatine kinase elevations are more common than symptomatic myotoxicity, but there were some cases clearly associated with raltegravir. If you look at the summary of product characteristics for each of the integrases, you can see these issues are uncommon, except for dolutegravir, where CK elevations and myalgia are listed as common. And for BICSTAR, there is no mention. Raltegravir, though, is the only one with a caution that raltegravir should be used with caution in people with a history of myopathy or rhabdomyolysis, or people who've got predisposing factors based on other medical conditions or medications. How do you manage this? I want to emphasize it is uncommon. Now, there's no role for sort of routine asymptomatic or pre-ART CK measurement, and we don't fully understand the impact of asymptomatic CK elevations anyway. Excluding other causes, of course, exercise being a very common cause of muscle aches and CK rises. Thinking about prescribed drugs, alcohol and cocaine are important causes, as is vitamin D deficiency, which can cause symptomatic myopathy. Within class switch seems reasonable, though there's no sense that if you've had myotoxicity on one integrase, you are more likely to get it on another. But if there does appear to be a class issue, of course, the option of switching to a different class. Moving on to CNS toxicity, I'm going to focus on two things here, suicidality and then insomnia. Now, thinking about suicidality, you can see that that's uncommon for all the integrases, whereas abnormal dreams are common. Of course, abnormal dreams are a common event anyway. But coming back to suicidality, it's again only for raltegravir, there's a specific caution that raltegravir should be used with caution in people with pre-existing depression or psychiatric illness. This is a German cohort looking at discontinuations for neuropsychiatric adverse events on elvitegravir, raltegravir, and dolutegravir, and you can see discontinuations were more common for dolutegravir. Of course, one must think about confounders, the fact that dolutegravir has a high barrier, fewer drug interactions, and is once daily may explain some differences between the population receiving that integrase compared to the others. However, there were some factors that were pulled out as predictive. So women and older people more likely to discontinue for this reason, but importantly, starting abacavir at the same time. And I will come back to the issue of abacavir here. So the importance of backbone. Gilead 1489 and 1490 were the two studies comparing bictegravir and dolutegravir first line. Let's look at 1489 first. Nausea and insomnia, you can see, were more common on dolutegravir than on bictegravir. So you could look at that and say that dolutegravir was less well tolerated. However, if that was the case, why did we not see a difference in 1490? Now, 1489 compared the two integrases, but with different backbones. So BIC was with FTC and TAF. Of course, it has to be, you have no other choice, but dolutegravir was with abacavir and lamivudine. In 1490, however, where you'll see there was no difference for insomnia and nausea rates, both integrases were given with the same TAF-FTC backbone. So arguably, rather than demonstrating a difference between the integrases, these studies show that the differences in nausea and insomnia rates were being driven by abacavir versus TAF. What about the management though? So thinking about insomnia, good history taking is really important, as is accurate sleep advice. That's a whole different topic, but there are lots of myths about sleep and some really sensible tips that can yield marked improvement. Reviewing the backbone, and anecdotally, where we've been simplifying people from abacavir, lamivudine and dolutegravir triple therapy down to dolutegravir, lamivudine dual therapy, we've had some people actually report improvements in sleep and GI side effects that they hadn't even described before. Morning dosing may help. I'll show you a paper that demonstrates that. Taking the Integrase without food where that's appropriate. And of course, switching class is always an option. In the future, we may be using pharmacogenomics to predict these types of side effects, and I'll come on to that also. So firstly, morning dosing, just want to highlight this paper here from HIV Medicine, and they described people experiencing insomnia on dolutegravir, and for the majority of them, it improved when they shifted taking their dolutegravir from the evening to the morning. And in terms of pharmacogenomics or pharmacogenetics, this study showed several single nucleotide polymorphisms in, for example, the cytochrome enzymes or UGT, that these SNPs were associated with differences in integrase concentrations. They also showed that integrase concentrations correlated with adverse events, including insomnia. And they also found actually it was raltegravir associated with more abnormal dreams than elvitegravir or dolutegravir. BIC was not included in this study, and I think it's worth pointing out it was not randomized and only included 84 people. The other pharmacogenomic study of interest is from Japan, and they looked just at UGT polymorphisms here. They showed a correlation between UGT polymorphisms and dolutegravir concentrations. They showed a relationship between dolutegravir concentrations and neuropsychiatric adverse events, and suggested that these polymorphisms may be a risk factor. Now, the field of pharmacogenomics is expanding as I speak, and in the future we may well be doing more than just HLA-B5701 testing in the field of HIV. Now, of course, bictegravir and dolutegravir are remarkably similar structurally. We know there are differences, so they have a different impact on metformin concentrations, for example, but they are very similar molecules, and the chances of them having grossly different toxicity profiles are quite small. I think here real-world data can be really important in guiding us. This is a summary of real-world studies for suppressed switch, where people have switched to dolutegravir and lamivudine, and there's also data for Biktarvy I'll come on to. But thinking about discontinuation, so again, these are people who were on suppressed treatment who switched to dolutegravir and lamivudine, and you can see across the studies fairly low rates of discontinuation, probably around 6.5 to 7.5% typically. What about Biktarvy? So the BICSTAR study was presented at HIV Glasgow last year, more than 500 people, but most of them treatment experienced, i.e. suppressed switch. And just moving on to this table, if we look at the far right column, thinking about the suppressed switch patients, again, discontinuations for adverse events, 7.7%. So what we're seeing in real life studies is similar discontinuation rates for adverse events for dolutegravir and lamivudine and for Biktarvy. So I think we can say they appear to be performing fairly similarly from a toxicity regard in real life. So to conclude, the evolution of antiretroviral therapy has led to marked improvements in toxicity and tolerability profiles. For the reasons I've explained, I think incidence and point prevalence of adverse events should be reported as standard in clinical trials. As adverse events get less common, post-marketing surveillance, reporting, and understanding mechanisms are all the more crucial, because then we can best counsel patients about the risk and best tailor antiretroviral therapy for them. I shall finish there with my contact details should you wish to get in touch, and thank you very much for your kind attention.